Hello everyone, my name is Haya Kaseer. I'm a PGY2 critical care pharmacy resident at UF Health Shands Hospital, and today I will be presenting my research project on fluid resuscitation weight-based dosing strategies in obese septic patients. Starting with a brief background on the sepsis core measure mandated by CMS, it is recommended to complete a couple of tasks within 3 hours and 6 hours of severe sepsis recognition in attempt to avoid progression to septic shock. Progression to septic shock per the CMS criteria is defined as either the administration of vasopressors or the presence of persistent hypotension after adequate administration of crystalloid fluids. There is limited evidence to support an optimal fluid dosing strategy in obese patients. Whether to calculate the initial 30 ml per kilogram fluid bolus using actual body weight, ideal body weight, or adjusted body weight, or alternatively using a non-weight-based dosing strategy. There are 3 main trials that looked at fluid resuscitation dosing strategies in obese patients. These trials present conflicting evidence of which weight to use in this patient population, with the first trial supporting the use of ideal body weight, and the second trial by Adams and colleagues that looked at actual body weight and found that it delayed time to hemodynamic stability, and the last trial showing potential mortality benefits using the adjusted body weight. Now that we have discussed existing literature, we will move on to discussing our current study. Our study is a single-centered retrospective cohort analysis conducted at UF Health Shands Hospital in Gainesville, Florida. You may review our listed inclusion and exclusion criteria on the slide, but just briefly, we have included adult patients with a BMI of at least 30 that had a severe sepsis diagnosis and were admitted to either our emergency department, our medical surgical units, or our intensive care units. Of the 1,300 screened patients, we excluded 1,228 patients, which left us with 49 patients in the ideal body weight group and 23 patients in the non-ideal body weight group. Our primary objective for the study was the composite of progression from severe sepsis to septic shock. And our secondary objectives were in-hospital mortality, ICU length of stay, and hospital length of stay. The patient's baseline demographics, comorbidities, and clinical parameters were quite similar. In this table, you will find sepsis-related interventions that were collected and analyzed. During the first 12 hours after the recognition of severe sepsis, the non-ideal body weight group received significantly higher volumes of fluid resuscitation in liter units and required initiation of mechanical ventilation in 13% of patients compared to only 2% in the ideal body weight group, demonstrating a non-significant trend towards acute respiratory failure in the non-ideal body weight group. There were no differences found in the rate of diuresis or initiation of renal replacement therapy within 24 to 48 hours after severe sepsis diagnosis. Therefore, renal function was likely preserved and did not contribute to acid-base disturbances requiring the use of mechanical ventilation. Now, looking at our study outcomes, we did not observe a difference in the progression to septic shock between the 2 study groups. Additionally, there were similar rates of persistent hypotension among the 2 groups, and none of our study patients required the initiation of vasopressors. In-hospital mortality rates and length of hospitalization and ICU stay were also similar between the 2 groups. We have identified several limitations in our study. First, we do recognize that BMI is an imperfect measure of obesity. This study has a retrospective design and a small sample size, which is another limitation. We relied on accurate EHR documentation of fluid, vasopressors, and diuretics, in addition to prompt recording of hemodynamic parameters. We do acknowledge that the traditional definition of severe sepsis is no longer recommended. However, we attempted to follow the CMS assigned definitions for both severe sepsis and septic shock based on the released revision to their sepsis core measure in February of 2018, which allowed the use of either ideal body weight or adjusted body weight for resuscitation in these patient population. Additional data on potential confounders were also not recorded, and that includes the source of infection, antibiotic choice, and the timing of antibiotic administration. So in conclusion, the administration of the initial fluid bolus using an ideal body weight dosing strategy did not advance progression to septic shock compared to a non-ideal body weight strategy. There were no mortality or length of stay differences identified between the two groups. And finally, we believe that prospective research trials are warranted to validate the optimal volume of fluid resuscitation needed for obese patients. And with that, I conclude my presentation today. Please feel free to contact me via the email address listed on the slide if you have any comments or questions regarding our study. Thank you very much for watching.